Welcome to Weekly Neurology Deep Dive. This program is produced by Omer Gavanini.
And, before we jump in, this audio is solely for educational purposes and has no commercial goal.
Right, it's only a summary.
Yeah.
So you are highly recommended to read the full paper we are covering today.
Yes.
Today, we are discussing the paper titled Comprehensive Multidisciplinary Care for Fragile X-Associated Tremor Ataxia Syndrome.
By Bourgeois and colleagues, right? Published in Frontiers in Neurology in March 2026.
Exactly. And just to give you a practical summary up front, this paper outlines the diagnosis and multidisciplinary clinical management of fragile X-associated tremor ataxia syndrome.
Yeah, it really emphasizes the necessity of early genetic testing for patients presenting with late-onset tremor or ataxia.
And the critical importance of avoiding delirium-inducing medications, along with the implementation of a comprehensive care team spanning neurology, psychiatry, and rehabilitation.
Right, a fully multidisciplinary approach.
So let's examine the underlying genetic paradox here. The medical community typically associates the fragile X genetic mutation with severe childhood intellectual disability.
Well, yeah, but here we are examining a condition where a partial version of this exact same mutation sits dormant for 6 decades.
Which is wild. It just sits there, only to manifest later as a progressive, adult-onset neurodegenerative disease.
Exactly. So let's look at the core genetic mechanism causing this distinct clinical presentation. It's caused by a premutation of 55 to 200 cytosine guanine repeats in the fragile X messenger ribonucleoprotein 1 gene.
And that gene is located on the X chromosome, correct?
You got it. And this differs fundamentally from the full mutation.
Right, because the full mutation involves over 200 cytosine guanine repeats and results in Fragile X syndrome.
Yeah, in that full mutation, the gene becomes methylated and silenced, resulting in a lifelong deficiency of the Fragile X protein.
And that lack of protein is what causes the severe intellectual disability and autism spectrum disorders observed in childhood.
Precisely. The premutation, however, operates through a completely different mechanism, which is known as toxic ribonucleic acid gain-of-function.
Well, could you detail the exact mechanism of this toxic ribonucleic acid gain-of-function for the practicing neurologist? How does a partial gene expansion actively destroy neural tissue decades later?
Sure. So the premutation does not silence the gene. Instead, it causes increased transcription.
Okay.
And this leads to abnormally elevated levels of messenger ribonucleic acid. This excess messenger ribonucleic acid is intrinsically toxic.
Because it actively binds and sequesters key ribonucleic acid binding proteins, right?
Right, proteins that neurons and glia require for normal cellular maintenance and survival. By sequestering these essential proteins, the messenger ribonucleic acid induces widespread oxidative stress.
As well as mitochondrial dysfunction and calcium dysregulation.
Exactly. And this process culminates in the formation of eosinophilic ubiquitin-positive intranuclear inclusions.
Wow.
Yeah, these inclusions physically accumulate within the nuclei of neurons and astrocytes.
And clinical pathology demonstrates that astrocytes are highly vulnerable to this ribonucleic acid toxicity.
Right, and because astrocytes provide essential metabolic support to the nervous system, their early death and the disease progression deprives the neurons of critical support.
Which directly precipitates subsequent neuronal death.
Exactly.
So that establishes the molecular foundation for the neurodegeneration. But what is the specific prevalence of this premutation in the general population?
The premutation prevalence is about 1 in 148 to 200 females and about 1 in 290 to 855 males.
Wait, and what is the lifetime risk trajectory for carriers developing the syndrome?
Well, carrying the premutation does not guarantee the development of fragile X-associated tremor ataxia syndrome. For males who carry it, the lifetime risk increases significantly with advancing age.
Rising from about 40% in their 60s to about 75% in their 80s.
Right. And the lifetime risk for females with the premutation is about 20%. Furthermore, the disease trajectory differs between the sexes.
Because males present with an earlier onset and a much more rapid clinical progression compared to females, right?
Yes. The average age of onset is about 60 years for males and about 70 years for females.
Before the motor symptoms emerge, the systemic ribonucleic acid toxicity affects other systems. The paper details 2 related conditions that affect premutation carriers earlier in life.
Right. The first is fragile X-associated neuropsychiatric disorders,
Which affects about 50% of premutation carriers. I mean, these patients experience psychiatric illness long before the motor symptoms appear.
Yeah, primarily presenting with severe anxiety and depressive disorders,
And the second condition is Fragile X-associated premature ovarian insufficiency.
which affects about 10 to 20% of female carriers. It's characterized by early menopause, often before age 40, and infertility.
And female carriers with this insufficiency face a reduced life expectancy, attributed to an increased risk of cardiovascular disease and osteoporosis.
Right, resulting directly from the prolonged loss of normal female hormone function.
So when the neurodegenerative phase eventually begins, the primary clinical presentation is defined by intention tremor and cerebellar ataxia,
Exactly. The intention tremor typically manifests first and is more prominent in the distal upper extremities.
which severely diminishes fine motor control, compromising manual tasks like writing, utilizing utensils, or dressing,
Yes, and as the disease progresses, the cerebellar ataxia develops.
causing broad-based gait instability, frequent falls, and a profound loss of independent mobility,
Right. And these progressive motor symptoms are frequently followed by a severe cognitive decline.
which is categorized by clinical neurologists as a frontal subcortical dementia
Oh.
or a major neurocognitive disorder.
Right, and this specific pattern of cognitive decline affects about 50% of males with the syndrome.
The frontal lobe impairment features prominent dysexecutive function, behavioral dyscontrol, impulsive behavior, and inappropriate social behavior.
While information processing speed is commonly slowed, the subcortical features include the concurrent movement disorders, mood symptoms, apathy, and slowing in speech and thinking.
The paper describes the concurrence of this abnormal executive function, impaired visuospatial and speech functions, and emotional blunting or disinhibition as the cerebellar cognitive affective syndrome.
Yes, that's a key concept here.
Well, could you connect the purely motor symptoms, the ataxia and tremor, directly to the severe psychiatric and executive function deficits seen in these patients? I mean, how does pathology in the cerebellum generate psychiatric disease?
That's a great question. The cerebellum does not merely coordinate physical movement. It actively regulates the rate, rhythm, and force of cognitive and emotional processes.
Oh, wow.
Yeah, so the syndrome damages the cortico-pontocerebello-thalamo-prefrontal cortical loops.
Yeah, they get.
Cortico-pontocerebello-thalamo-prefrontal cortical loops. These complex neural circuits link the prefrontal cortex down to the pontine nuclei, into the cerebellum, project back through the thalamus, and return to the prefrontal cortex.
Right, so when the ribonucleic acid toxicity demyelinates and destroys these specific communicating loops, the prefrontal cortex loses its regulatory feedback from the cerebellum.
Exactly. This structural disconnection results directly in the concurrent dysexecutive function, behavioral disinhibition, and affective signs.
Including profound apathy, anxiety, hostility, and irritability.
Right. The disease process also causes additional systemic symptoms due to the widespread nature of the inclusions.
Like peripheral neuropathy, significant autonomic dysfunction, dysphagia, choking, and chronic constipation.
Yes, and in male patients, erectile dysfunction is highly common.
Furthermore, Parkinsonian features, which include resting tremor, flat facies, and a shuffling gait, are present in about 30% of patients.
Yeah, pathology studies actually indicate that a small percentage of these patients possess both the typical ubiquitin-positive intranuclear inclusions and the Lewy body inclusions classically seen in Parkinson's disease.
Let's examine how this clinical presentation unfolds over time, progressing through 6 distinct stages.
Right, so in stage 1, patients exhibit subtle or questionable tremor and balance problems. These are frequently overlooked as benign essential tremor or normal aging.
And in stage 2, the mild tremor and balance problems become undeniable upon examination, but they have limited interference with activities of daily living.
By stage 3, more pronounced tremor and balance problems lead to significant physical difficulties, restricting mobility.
And in stage 4, the severe tremor and ataxia necessitate the constant use of assistive devices, like a cane or walker.
Right, and dependency on caregivers increases substantially. By stage 5, the patients become full-time wheelchair users.
With highly limited ability to ambulate independently.
Exactly. Finally, in stage 6, patients become entirely bedridden, requiring around-the-clock care for all activities of daily living.
Presenting with profound motor impairment and end-stage major neurocognitive disorder.
Now, diagnostic confirmation requires meeting major clinical criteria, specifically intention tremor and gait ataxia, combined with crucial radiological criteria.
Neurologists must also evaluate the patient's multi-generational pedigree. Because the gene is located on the X chromosome, all mothers of Fragile X males are obligate premutation carriers.
Right, and these maternal carriers have elevated risks for thyroid disease, autoimmune disorders, and those anxiety and depressive disorders we mentioned earlier.
So genetic counseling is critical to identify at-risk relatives across the family tree, facilitate cascade testing, and support reproductive decision-making.
Definitely. As for the radiological criteria, they are evaluated using MRI.
The neuroimaging hallmarks include white matter hyperintensities, which represent areas of demyelination, axonal loss, and gliosis.
Yes, MRI white matter hyperintensities in the middle cerebellar peduncles are seen in about 60% of male patients.
This is often referred to as the middle cerebellar peduncle sign.
Right. Female patients typically exhibit a different pattern, frequently presenting with white matter hyperintensities in the splenium of the corpus callosum.
High-intensity signals at the corticomedullary junction are also frequently reported.
And as the disease advances, cortical atrophy and ventriculomegaly become highly prominent. Volume loss in the whole brain, cerebellum, and brainstem occurs progressively.
Mirroring the widespread astrocyte and neuronal death. The total volume of periventricular and supratentorial white matter hyperintensities correlates directly with the clinical progression of the cognitive decline.
And the severity of the motor symptoms.
You mentioned resting tremor and flat facies occurring in about 30% of patients.
Right.
If a patient presents to a clinical neurologist with those specific symptoms, the immediate clinical instinct is to diagnose Parkinson's disease.
Of course.
How does a neurologist definitively differentiate fragile X-associated tremor ataxia syndrome from Parkinson's disease or from other phenotypically similar conditions like neuronal intranuclear inclusion disease?
Well, while the Parkinsonian features often lead to misattribution to Parkinson's disease, you must focus on the primary major clinical criteria.
Intention tremor and cerebellar ataxia.
Yes, they are the prominent defining features here, whereas Parkinson's disease is classically defined by resting tremor, bradykinesia, and rigidity without early pronounced ataxia.
Right. And what about neuronal intranuclear inclusion disease?
Differentiating from that is significantly more challenging clinically. Both conditions present with tremor, ataxia, severe cognitive decline, and very similar MRI findings.
Including the white matter hyperintensity.
Exactly. Therefore, a definitive diagnosis relies exclusively on deoxyribonucleic acid testing.
Because deoxyribonucleic acid testing reveals the exact cytosine-guanine repeat number expansion in the fragile X-messenger ribonucleoprotein 1 gene.
Right. In contrast, neuronal intranuclear inclusion disease involves nucleotide expansions in an entirely different gene, the NOTCH2-NLC gene.
Oh, I see.
Furthermore, if a tissue biopsy is performed, the intranuclear inclusions of fragile X-associated tremor ataxia syndrome are never seen in fibroblasts.
Whereas fibroblasts are a typical location for the inclusion seen in neuronal intranuclear inclusion disease.
Exactly.
Now, the paper issues a strict warning regarding hospitalizations and medication vulnerability in this specific patient population.
Yes, patients experience frequent infections due to immune system impairment resulting from the ongoing ribonucleic acid toxicity.
Simple, routine infections like a urinary tract infection or pneumonia can lead to abrupt and profound neurological dysfunction.
Including severe generalized weakness and a sudden lack of ability to walk.
The paper states that after the onset of major neurocognitive disorder, these patients must be managed as highly delirium-prone.
Right. The contraindicated medications include benzodiazepines, anticholinergics, opioids, antihistamines, and general anesthetics.
The paper particularly warns against the general anesthetic isoflurane. Detail the mechanism behind this extreme medication vulnerability for us. Why do they react so severely?
Well, the chronic neuroinflammation and progressive astrocyte death severely compromise the structural integrity of the blood-brain barrier.
Making it function abnormally.
Right, allowing medications that would typically remain largely in the peripheral circulation to easily penetrate the central nervous system.
Which significantly amplifies the central nervous system side effects of any centrally acting drug.
Exactly. Administering a standard clinical dose of an anticholinergic medication or benzodiazepine to these patients can rapidly precipitate profound life-threatening delirium.
Wow. And regarding surgical interventions, why is the general anesthetic isoflurane strictly warned against?
Because preclinical evidence demonstrates it directly induces neurotoxicity and accelerates cellular apoptosis in the context of fragile X-messenger ribonucleoprotein 1 premutations.
Okay, so the pharmacological approach for managing the motor symptoms requires extreme caution. For tremor management, clinical neurologists can utilize primidone, levetiracetam, gabapentin, or beta-adrenergic blockers.
Right. And when the Parkinsonian features are present, carbidopa can be utilized.
However, neurologists must maintain a low threshold to rapidly discontinue carbidopa if there is no meaningful symptom improvement.
Or if the medication precipitates psychotic symptoms or worsening agitation.
So given the fragile blood-brain barrier and extreme medication sensitivities, how should the clinical neurologist safely manage the highly prevalent anxiety and depressive disorders?
Well, selective serotonin reuptake inhibitors remain the first-line treatment.
But due to significant drug interactions with multiple other medications processed through the cytochrome P450 system, sertraline, citalopram, and escitalopram are preferred.
Yes, those are safer options. But a strict clinical warning must be issued regarding these psychotropics.
Because there is a high risk of the syndrome of inappropriate antidiuretic hormone associated with selective serotonin reuptake inhibitors in these frail patients.
Right. This syndrome alters the renal response, causing the body to retain water and dangerously dilute serum sodium.
And this resulting hyponatremia occurs in a euvolemic state and frequently presents identically to delirium or rapid cognitive decline.
Exactly. Serotonin norepinephrine reuptake inhibitors have a similar mechanism of action and are subject to the exact same cautions regarding hyponatremia.
Though their added noradrenergic activity can be uniquely beneficial for managing the painful peripheral neuropathy often seen in these patients.
Right. Dopamine norepinephrine reuptake inhibitors, such as bupropion, are preferred for depressed patients who present with prominent hypersomnia and weight gain.
But the clinician must monitor the patient closely because the stimulating effect can severely exacerbate the underlying intention tremor.
And mirtazapine is utilized specifically for melancholic depression, accompanied by prominent insomnia and a severe lack of appetite.
What is the recommended management strategy for severe irritability, impulsivity, or psychotic symptoms when they inevitably arise during the frontal subcortical dementia phase?
Mood stabilization with anticonvulsants can be helpful to manage behavioral discontrol. However, valproate carries serious systemic risks, including hyperammonemia, hepatotoxicity, and pancreatitis.
Requiring constant laboratory monitoring.
Yes. Carbamazepine carries high risks for hematologic and hepatic side effects. Furthermore, both valproate and carbamazepine carry high risks for precipitating the syndrome of inappropriate antidiuretic hormone.
Lamotrigine can be utilized, but it carries the well-documented dermatological risks of toxic epidermal necrolysis and Stevens-Johnson syndrome.
Right. Lithium is usually avoided entirely due to the high systemic medical risks in an elderly population and the direct risk of exacerbating the cerebellar tremor.
And second-generation antipsychotics have a documented increased morbidity and mortality risk in patients with dementia.
Exactly. So they must not be used non-specifically to chemically restrain agitation.
If an antipsychotic is absolutely necessary, quetiapine is the preferred option in patients with concurrent movement disorders.
Yes, due to its significantly lower level of dopamine receptor blockade, which minimizes the risk of worsening the Parkinsonian features or ataxia.
Cognitive decline management involves therapeutic trials of acetylcholinesterase inhibitors and memantine.
While these medications are completely unlikely to reverse existing impairments, they are utilized to slow the expected rate of ongoing cognitive decline.
Though acetylcholinesterase inhibitors must be held if the patient's pulse drops below 60 beats per minute due to their vagatonic effects.
Right. A previous controlled trial of memantine specifically in this syndrome did not improve the tremor or the ataxia, but it did demonstrate measurable improvements in memory and auditory processing on event-related potential studies.
The complexity of this pharmacological management illustrates why the necessity of a coordinated care team extends far beyond medical interventions into multidisciplinary rehabilitation and support.
Absolutely. Physical therapy is an absolute requirement for balance training, core strengthening, and mitigating the immense fall risks associated with cerebellar ataxia.
Aquatic therapy offers a specialized low-impact environment where the hydrostatic pressure provides postural support.
Which makes it highly conducive to improving balance without the immediate fear of falling.
Right. Occupational therapy focuses heavily on adapting activities of daily living and implementing necessary home modifications.
This includes prescribing weighted utensils to mechanically counteract the intention tremors during meals, or installing grab bars and shower chairs in bathrooms to prevent catastrophic falls.
And speech and language pathology is critical to manage the dysarthria, which impairs clear communication and the life-threatening dysphagia.
Because the bulbar muscle incoordination causes severe swallowing difficulties.
Right. And untreated dysphagia leads directly to severe weight loss, clinical dehydration, and aspiration pneumonia.
So the speech pathologist implements specific swallowing maneuvers, prescribes precise diet texture modifications, and trains the patient on positional strategies during meals to protect the airway.
Systemic care managed by the multidisciplinary team must also include a rigorous assessment for sleep apnea. Sleep apnea causes intermittent nocturnal hypoxia. Detail the specific danger of hypoxia for this patient population.
Well, the brain's white matter is highly vulnerable to oxygen deprivation. For a patient who already has severely damaged white matter resulting from the ribonucleic acid toxicity, the addition of repetitive hypoxia rapidly accelerates the demyelination process.
Which directly worsens the white matter hyperintensity seen on the MRI and accelerates the cognitive decline.
Therefore, continuous positive airway pressure therapy is absolutely essential to protect the remaining white matter if sleep apnea is diagnosed.
Furthermore, the clinical neurologist must counsel patients to eliminate exposure to neurotoxins.
Right. Patients must minimize or completely eliminate the use of alcohol. Alcohol has directly toxic effects on Purkinje cells and further degrades cerebellar function.
And regular cardiovascular exercise is highly recommended because it lowers systemic inflammation and improves mitochondrial function.
Directly combating the oxidative stress caused by the premutation.
Finally, an audiology evaluation is necessary. The syndrome can impact cranial nerve 8, leading directly to sensorineural hearing loss and chronic tinnitus.
And older adults with untreated hearing loss are at a significantly heightened risk for social isolation, depressive disorders, and a more rapid acceleration of their cognitive decline.
Non-medical interventions, such as cognitive training programs, offer a promising adjunct to standard therapy. Digital platforms provide targeted exercises designed to engage executive functioning, memory, attention, and processing speed.
Right. And systematic reviews demonstrate statistically significant improvements in cognitive outcomes among older adults engaging in digital cognitive training, particularly when combined with routine physical exercise.
The multidisciplinary team must also direct significant resources toward the caregivers. The emotional and physical toll of providing full-time care for a patient with profound physical and behavioral deficits leads to extreme caregiver burnout.
And psychiatric symptoms. The primary caregiver is often significantly depressed, sometimes presenting with worse psychiatric symptoms than the patient themselves.
So engaging the caregiver in individual psychotherapy, focusing on cognitive behavioral therapy, acceptance and commitment therapy, and existential therapies promotes vital psychological adaptation and resilience.
Because of the progressive nature of the major neurocognitive disorder, advanced care planning must begin exceptionally early in the disease progression.
It is ideal to establish advanced directives no later than stage 4, which is the stage when patients first require a walker or a wheelchair for mobility.
Right, this critical planning must occur while the patient still retains executive function, well before the major neurocognitive disorder impairs their legal decisional capacity.
Documenting explicit goals of care, advanced directives, establishing a durable power of attorney for healthcare, and drafting physician orders for life-sustaining treatment ensures that all future medical interventions align strictly with the individual's personal values.
This rigorous early planning facilitates a seamless transition into necessary palliative and hospice care during stages 5 and 6.
At the final stages of the disease, the clinical focus shifts entirely away from disease modification and centers exclusively on aggressive symptom relief.
Right, the medical team addresses physical discomfort, pain management, severe mood symptoms, and sleep problems.
Ensuring maximum safety, dignity, and comfort for patients who are bedridden and possess profound cognitive impairments. So, for the clinical neurologists on the go, the practical summary of this deep dive is reiterated. The paper emphasizes the absolute necessity of deoxyribonucleic acid testing for the fragile X-messenger ribonucleoprotein 1 premutation in all adults presenting with late-onset ataxia or tremor.
Clinical management requires aggressive avoidance of delirium-inducing medications due to blood-brain barrier dysfunction,
along with highly cautious pharmacological treatment of both motor and psychiatric symptoms, and the early integration of a multidisciplinary rehabilitation team, along with early advanced care planning.
The clinical evidence shows that toxic messenger ribonucleic acid accumulation and subsequent astrocyte death occurs silently over decades, well before the clinical onset of the visible motor symptoms. Given this prolonged preclinical phase, how might the development of future early screening protocols for asymptomatic premutation carriers fundamentally alter the timeline for neuroprotective interventions, potentially allowing neurologists to halt the ribonucleic acid toxicity before the very first astrocyte even dies?